Mi nombre es Tania Portillo, vivo aquí en el centro California. Mi hija se llama Audrey Valenzuela, estudia en la Southwest, estudia en la high school, es una niña fenomenal, me ha ayudado bastante. Y aprendió a manejar, le enseñamos a manejar porque hay veces que uno se siente pues mal, ¿no? Entonces es una niña que es muy dura, es muy fuerte con lo que hace. De hecho ahorita está allá afuera esperándome y siempre me ha apoyado y dice que, o sea, al momento de decir, mamá, es cáncer, yo no sabía ni cómo explicarle, ¿no? O sea, cómo decirlo. Entonces dije, no, pues voy a hacerlo de la misma manera como yo soy. Entonces yo se lo dije, ¿sabes qué? Le dije, me detectaron una bolita en el seno, se tiene que quitar y me va a tocar pasar por el proceso. Va a haber días buenos, va a haber días malos. Entonces como que, ok, ¿es cáncer? O sea, ella lo entendía, ¿no? Porque ella está grande. ¿Eh? Yo no quería utilizar esa palabra tan fuerte, ¿no? Pero lo hemos llevado muy bien, bendito Dios, y es lo que tengo, es una gran compañera ella para mí. No, estaba trabajando en el Hampton Inn, pero después de la pandemia, pues me quedé sin trabajo y fue cuando empecé con el problema de lo del cáncer. No tengo familia aquí en el centro de California, mi familia vive en Mexicali. Yo creo que es lo normal que cuando dicen en los videos, ¿no? Que dicen que las mujeres nos tenemos que estar tocando nuestras áreas del cuerpo para saber conocernos, ¿no? Más que nada. Y de esa fue la manera que yo me di cuenta. Yo toqué mi seno, en el cual yo encontré una bolita que medía 2.5 centímetros. Um, Fue una experiencia con miedo, con temor, yo creo, ¿no? Yo creo que para toda mujer que recibimos ese tipo de encontrarnos ese tipo de cosas en nuestro cuerpo, ¿no? Cuando yo me doy cuenta, pues decido irme a tratarme, a revisarme con un doctor. Solamente fue una ocasión, voy con una doctora, un ginecólogo, hace creo que le llaman palpar o algo así en el seno. Ella miró algo mal, me manda a hacer un ultrasonido mamario, el ultrasonido mamario me mandó con otro especialista. Estamos hablando que fue de 3 días. Después me hice una biopsia, entonces lo hice yo allá en Mexicali. Cuando ya me dan los resultados, pasó una semana o 7 días, me dan los resultados de que si era cáncer, pues ya fue cuando yo me vine con esa hoja a ofrecerse, a enseñársela al doctor Razzaque. La miran y el doctor Razzaque decide pues tomarme como paciente y empezar a hacer todos sus estudios por él mismo. Al momento de yo ir con el doctor Razzaque y llevarle mi diagnóstico que me venía de Mexicali, el doctor decidió hacerme todos los estudios. Entonces tuve que pasar por todo ese tipo de dolor que pasamos las mujeres, por un mamograma, por otra biopsia. Fue todo un procedimiento. Al momento que el doctor ya con sus estudios de él mismo se da cuenta el tipo de cáncer que manejaba o que tenía yo, él me comentó que si yo quería tener, si tenía hijos o quería tener más hijos. Yo le comenté que solamente tenía una hija y quería tener más hijos. Entonces él me dijo, me dio la ubicación de aquí con ustedes para que ahí me podían a lo mejor ayudar. Yo lo dejé visto así como que, ok, está bien, otro tipo de ayuda. Nunca me imaginé el tipo de ayuda que me iban a ofrecer. Mira, la verdad, soy una persona muy optimista, soy muy fuerte y siempre he sido la parte fuerte de la familia, yo siempre lo he dicho. Tengo una hija que también es súper fuerte con todo esto, entonces creo yo que nunca nos hemos dejado sentirnos tristes. Va a haber días grises, como todos, pero no es algo, digo, esto es pasajero, me tocó, pero no hay por qué quejarse de las cosas. Simplemente yo creo que hay que aprender de todo. Siempre se aprende tanto de lo bueno como lo malo. Yo creo que las personas, todos somos diferentes. Cada cabeza es un mundo. Entonces, yo entiendo a las mujeres. Ahora puedo entender. Ahorita, el momento de yo ir a oncología, conozco a mucha gente, trato con muchas personas, escucho la historia o empiezan a platicar. Y hay gente que sí le da mucha tristeza, le da miedo, tienen miedo de decirle a sus familiares. Hay personas, pacientes que no les dice la familia por lo que están pasando, por el miedo al rechazo. Así que yo les invito a que puedan tratar, primero que nada, si sienten cualquier parte de su cuerpo, algo que no es que digan ustedes, no, esto no es mío, esto está algo mal. No se esperen que pase tanto tiempo, revisen, porque lo mío fue de 2.5. Dice la doctora que es algo que se puede sentir el de 2.5, a lo mejor menor no lo hubiera sentido, pero pues estamos hablando que en todo el cuerpo, ¿no? Alguna manchita, algún dolores que a veces uno no tengamos, no lo dejemos pasar. No pasa nada, revisarnos, checarnos, tocarnos. Somos mujeres y en nuestro cuerpo nos tenemos que querer y amar para poder salir adelante de todo esto. Así que las invito a que puedan, hay varios lugares donde nos pueden apoyar, tanto económico como ayuda psicológica también. Así que cualquier cosa, una de las situaciones que a mí me están ayudando o me ayudaron, que estoy muy contenta y muy agradecida, es cuando el doctor me dice que yo quería tener más babies. Yo nunca me imaginé que me iban a ayudar con eso y me ayudaron a poder congelar mis óvulos. Tengo 32 años, así que yo cuando me dijeron eso dije, bueno, tal, ya tengo una hija, pero tengo la oportunidad de tener otro hijo más y te ayudan con tarjetas de gasolina para ir a San Diego, te pueden ayudar para poder hospedarte también allá si es necesario. Hay muchas cosas y muchas ayudas que la gente que no sabe, pues, y más aquí en el Valle Imperial. Entonces, para que nos puedan apoyar para poder seguir teniendo ese tipo de ingresos.
My name is Irene Su. I am a reproductive endocrinologist and an epidemiologist. I am a professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at UC San Diego. I've had the good fortune of directing the fertility preservation program for cancer patients here at UC San Diego for about 10 years. Cancer treatments can differentially impact the ability for young adult cancer survivors to have kids in the future. And for females particularly, because we're born with a finite amount of eggs, some but not all chemotherapy can hurt that finite pool of eggs. And so if you are at risk for losing the finite amount of eggs that you have, then there are effective ways to try to preserve eggs, embryos, or other procedures to try to protect young women's ability to have their families later. So not every cancer treatment will harm fertility, but there are some drugs that are known to reduce the number of eggs, if not ablate all of the eggs that a woman has. In this case, a woman's risk is really based on both the type of treatment she's going to have and how old she is at the time. And so in breast cancer patients, I think there are really two primary risks. One is if the chemotherapy has a drug called cyclophosphamide, we know that that can reduce the egg number. Maybe it's not all gone, but reduce. That's known from animal model and from human data. But the other piece of it is that many people who have breast cancer are on endocrine therapy for 2 years, 5 years, 10 years, because what you want is for the body not to see a lot of estrogen during this time to prevent the cancer from coming back. Those treatments do not directly hurt the number of eggs we have, but we're aging at the same time. And because these breast cancer patients are being diagnosed when they're young, like in their late 20s, early to mid 30s, 2, 5, 10 years later really has an impact on your reproductive lifespan. For every newly diagnosed cancer patient who is young, there should be some talk about whether cancer treatment poses a risk to your fertility or to your reproductive health. And then for those people who have great desire to grow their families later and who are at some risk, then they think about these fertility preservation options. So that's sort of medically what's indicated. But in the Valley, there are additional barriers because it's so complex to link oncology and reproductive medicine, to do it in a timely manner, because treatments like egg freezing, embryo freezing, or even surgery to move ovaries out of the way of radiation in some cases, they take a couple of weeks. And you want to balance giving people their most reproductive options, but not delaying cancer treatment in a way that would harm their cancer outcome. And so you add on top of this the great distance that patients have to travel when they live in the Valley to have to come to an urban specialist care center. And then on top of that, language, cultural barriers, I think, are all things that young women who are in Imperial Valley, who are primarily Spanish-speaking, probably face in addition to the already difficult situation of being a young cancer patient. So we talked about some of the challenges that face patients who live really, really far from urban centers, and potentially language and sort of cultural differences in the approach to women's health and reproduction. So we try to generate procedures, tools, referrals to help make that better for patients in Imperial County. And Tania was really our first patient to go through this process, and we learned a lot. So in urban centers, so here on campus at UCSD, there are electronic health record tools to help oncologists refer to us. There's a lot of staff calling the patient, then the patient comes in to be seen, and so forth. But in this case, because egg freezing, embryo freezing takes 2 weeks, when you come in, there needs to be a lot of different medications that need to be ordered for you. Those medications, the timing of these injections, they're all time sensitive, and much of that is delivered by yourself. So for example, our patients give themselves injections sort of in the skin of their belly every night for 10 days. And you come into clinic so that we can use ultrasound and blood work to make sure that your ovarian stimulation is going well, like not too much, but enough for it to be effective later. So this is where we really needed the bridge between myself, the oncologist, so that they knew when Tania was going to be done and ready to start cancer treatment, and CRCD and navigators and the nurses here, because literally it was evening calls when needed to say, when is this injection going in? Or I'm almost out of drugs. How do we get this? So there's like a lot of navigation that needed to happen. So other things that shifted for our practice is that there is one particular medical assistant who is more fluent in Spanish. And so we arranged for that medical assistant to really help take care of Tania every time she came into clinic. But those things that I think we really needed someone like Tania to come through so that we can refine our processes. And over time, if we're able to help more patients like Tania, we will learn from those experiences and essentially try to streamline. I think that there are a lot of oncology navigators around the country who would like to know how to navigate oncofertility. So this is our goal. So it's our hope that after cancer treatment, Tania is well, 1, 2, 3, 4 years from now, and she's ready to grow her family. And at that point, she and I are going to hopefully use telehealth to have a conversation about trying to become pregnant on her own. If she has trouble becoming pregnant because of the loss of eggs, then we will have these eggs here for the future. And what that would mean at that point is that we would thaw those eggs, fertilize with the sperm of her sperm charming in the future, generate embryos, and put one embryo back at a time for Miss Tania. And the rationale for putting one embryo back at a time is really because ultimately we want the same thing, which is a healthy mom and a healthy baby. And to have multiple pregnancies is always more dangerous for mom and more dangerous for baby. And so because the technology of freezing embryos and eggs is so good now, the idea would be hopefully we can generate multiple embryos, put one back, but freeze everybody else in case Miss Tania wants to grow her family to more. I'm a clinician at heart, but have always thought that if we can use research to answer clinically relevant questions, then those results can reach more people than the one patient at a time that I'm seeing. And so my research group has really worked on how do you identify reproductive risk, and now how do you deliver those risks to the patients and their providers so that that would inform whether they do things like fertility preservation. So it was one of the research trainees in my laboratory who met Helen's team when they were both when they were presenting research findings. And this is how we connected. I think it was really over Christmas break a couple of years ago that then we connected. And I think what we bring to the partnership is really complementary. They understand what is the patient need and what is that patient need for Latinx population and what is that patient need in Imperial Valley. And then on this side, we bring the clinical expertise in reproductive medicine and some of the research expertise in how do you conduct clinical trials? How do you conduct implementation science studies? How do you develop interventions to help deliver this service? And so we partnered, and in a very short amount of time, presented this idea of developing a pathway for oncology patients in community and rural centers to come into urban oncofertility care. And we were supported from through a grant from the California Breast Cancer Research Program. So that's what on the research side we've been working on for about a year and change, alongside actually asking patients and providers and stakeholders in Imperial Valley whether we're on the right track. So the process that young women will go through to try to freeze eggs or embryos starts with over about 2 weeks' time using medicines, the same hormones that our brain makes, FSH and LH, to push the ovaries to, instead of growing only one egg a month, to growing multiple potential eggs a month. Then, through surgery, where along the vagina there is a small needle that goes through the vagina into the ovary, retrieve eggs. Once eggs are retrieved, eggs can either be frozen, so this is the process of vitrification from left to right, which is freezing an egg, or they can be fertilized with donor sperm or partner sperm in order to generate embryos. So what you see here is on the left, a fertilized egg that over 3 days becomes a 4 to 8 cell embryo, and over 5 to 6 days becomes a type of an embryo called a blastocyst. There are a clump of cells here that eventually becomes the fetus and then became us, some fluid, and on the outside of this sphere, some cells that become the placenta.
My name is ADAY URIAS. I am a patient navigator here at the Cancer Resource Center of the Desert. I have helped Tania, which I met her back in October of 2020. She has breast cancer, stage 2. She was referred by El Centro Regional Medical Center, the Oncology, by Dr. Razzaque. And at first, when they were looking at her diagnosis and the possibility for chemotherapy, he did ask her if she wanted to have more kids because she does have a 15-year-old daughter. She said yes. In the case of Tania, for example, her chemotherapy, because it was so strong, it could kill these eggs, or she could go on early menopause. It all depends, which chemotherapy affects the body, but it had to be also prior her Mediport placement because of the anesthesia. So all that could, it could affect her fertility and her egg count and her hormones. So that's why everything had to be done prior treatment. She is breast cancer stage 2. It's an early stage, but in her case, she's triple negative, which means her histology, being the estrogen, the HER2, the hormones, they're all negative. So they went in very aggressive. Her chemotherapy is very aggressive, and this is the reason why it was going to affect her fertility. She speaks primarily Spanish. She understands very little English, so we were able to support in that way. She was also very overwhelmed by the amount of information and the amount of instructions that she had to follow. So that's where also we would come in and support and just reassure her that she was doing everything correct. And well, just a reminder, here at Cancer Resource Center, we are bilingual. We are able to help in Spanish or in English, whichever language that the person or the patient is most comfortable with. And like I said, it doesn't matter if you speak English or Spanish. We are here to help and support. What we initially did is we connected her with Dr. Su. She's from UC San Diego, and she's an Oncofertility doctor. She's a specialist. Because of the distance of being at San Diego and because of COVID, we were able to have a telehealth appointment with Dr. Su and her team. I was there at the time of the appointment because I had to translate the appointment for Tania. Since she was having phone issues, she couldn't connect through the UCSD system, and she needed somebody to translate. So I was able to be there and be that translator for Dr. Su and Tania. We've been learning a lot. We've been working with Dr. Su for now about 2 years. And I do have some training on oncofertility that I did through Moffitt University. So all that training and everything, it helped with her case, with Tania's case. And once she had her consult, Dr. Su gave her recommendation and provided all the information. When she went back to Dr. Razzaque, and he let her know that yes, she will be having chemotherapy. This will be affecting her fertility. She went ahead and went to San Diego for another follow-up appointment with Dr. Su, and the journey started for fertility preservation. It took about 2 weeks of her, Tania, going back and forth to San Diego, and her with medications, some that had to be self-administered. And she was able, at the end of that fertility preservation, she was able to freeze 15 eggs. And those are frozen for when she's ready to go back and, have a baby or 2. It's up to her because she has 15 available. But it's been a journey. It's been a great learning opportunity for us as well. And being that guiding hand through the whole process, because the instructions were very specific, times were specific, everything that was communicated to Tania was in English, so I had to step in and translate all that instructions to Tania. And just having her come in, pick up gas cards so that she had to go almost twice or once a week, if not more. And we've just been part of that journey for fertility preservation for Tania. It was with the intent to bring these services to these patients because it is something that is not offered here in Imperial County. Oncofertility is not offered. So this partnership, of course, is giving access to the patients who want to information, who want to do fertility preservation, and it just makes our services stronger for these patients that would like to access those services. And it's also the partnership that we have with ECRMC, being that we are a contractor with them, because it made everything flow easier, because it had to be communication not only with Dr. Su at UC San Diego, but also with Dr. Razzaque at ECRMC. It really have to be a coordination of care, of appointments, of dates, of when does treatment start, when does it end, so that she could take care. Fertility preservation has to be prior chemotherapy. So we had to do all that coordination of care so that she was taken care of. So our services that we provide and that coordination of care, it just makes stronger for our community, and this just makes it easier for the patient. Tania already had her fertility preservation. She already froze her eggs, but right now she is in treatment. She is doing chemotherapy, so it doesn't end there. We are still providing care for her, especially because right now she's in treatment, and it doesn't end after she's done with treatment. Sometimes there's things that linger, and problems and concerns that maybe she needs help and support. So our services really stop when the need is met. But let's say that in the long run she has another need, a different problem, she can always come in and come back so that she can receive those services. So all of the donations that are made are not only just for the efforts to provide patient care and direct services, but it also helps us as a team to provide more information for us to get more training on matters like fertility preservation and matters like research. There's not a lot of people doing research here in our county, and it's very important because Latinas are underrepresented in research, and us bringing the research here to our county and our community, it allows for the rest of the nation to even use this information for future research, or just information for their clients themselves. So your donations help CRCD in many ways, and this is one of them. It is patient care, direct services, but it's also in the research.